on another study we're involved in today. But today I'll be talking about developing an online platform to improve social connections for older adults living with HIV. Today we're not talking about how the focus groups went. We're talking more about some technological challenges that we had and what we learned from those while conducting the multi-site focus groups. The presenting problem is that older people living with HIV, age 50 years and older, tend to face unique health challenges and social isolation exacerbated by the COVID pandemic. So what we hope to conduct to solve social isolation and improve depressive symptoms among this population is to create an online platform that can connect them to community resources, service providers, and to each other. As I mentioned, today we'll be talking about the lessons we learned regarding the technological barriers we encountered during the facilitation of the focus groups with older people living with HIV. In this study, we had two phases. One was to form a community advisory board, which is comprised of older people living with HIV, age 50 plus. We have 24 members from all three study sites, including Palm Springs, California, Los Angeles, California, and Tampa, Florida. And then we were going to conduct our virtual focus groups. We conducted 9 focus groups with older people living with HIV with an aim to characterize the challenges they faced during the pandemic and to solicit feedback on developing an online platform and what they would or would not like us to include in our platform prototype. During this process, we identified cross-cutting themes related to technological barriers encountered while conducting the focus groups. This is just a screenshot of one half of our community advisory board members during a meeting we held in May. We hold meetings every month. And we get to talk about where we're at in the research process, get feedback and input on different study materials like the focus group questions that we asked participants. And it's been a really great opportunity to have community-led and directed research. Here are some demographics of who participated in our focus groups. So we had 57 participants total. The mean age of participants was 59.8 years, and 17.5% of our participants identified as Hispanic or Latinx. Our gender identity, most participants identified as male, 45 out of the 57. And for race, most participants identified as white, that was 64.1% of our participants. And Black or African American participants, there were 29.8%. And then we had American Indian and Alaska Native and an Asian participant. So here I'll get into our lessons learned. Our first lesson learned is that it's important to optimize access to Zoom by providing user-friendly, simple instructions prior to the start of the sessions. So what we learned is that many participants needed one-on-one technological guidance to participate comfortably in the focus groups. Not all of them were familiar with using Zoom. And so when we provided detailed, easy to follow instructions after they were enrolled, it helped familiarize them with the meeting platform, and it helped us to efficiently manage time leading up to the focus group. The second lesson learned was that it's important to be flexible with varying internet connectivity and bandwidth issues. Some participants that attended preferred to dial into the meeting, and they also had issues with internet connectivity sometimes during the sessions. So what we learned is that it's important to be mindful of their internet access, as well as the ability to maintain a stable connection for the duration of the session. So being able to provide flexibility and alternative methods to join, like dialing into the meeting rather than having to have your video on, that may enhance participant engagement. Our third lesson learned is that it's important to create an alternative approach to incentives. So we recruited and had participants who were older, who were at least 50 years of age. And so when we provided the e-gift cards, we used a major online retailer as our incentive. Many of our participants didn't have any prior experience with this retailer, and they weren't aware of how to redeem the card. So we learned that in the future, it's going to be important to provide alternative incentives for older people living with HIV, or to provide that additional instruction on how to redeem an e-gift card. Our fourth lesson learned is that it's important to use individualized methods of communication to inform and remind participants. So many of our participants did not regularly check their email, and they would miss important correspondence. This could include the consent survey that we provided before attending the focus group, as well as the Zoom link itself. So it's important to communicate with them by other means. A lot of participants also only had access to a landline, or they infrequently utilized text messages. So communicating just by giving them a call on the phone, that proved the clearest way to assist with helping them navigate Zoom and helping them understand how to use the e-gift card, as well as reminding them of important correspondence like the consent survey. Our future directions. So an online platform does have the potential to enhance aging in place and social connections, but we do want to note that there have been unique challenges that we need to address while conducting the remote interviews and the focus groups using Zoom or phone for this population. Following the lessons learned, the 4 lessons learned that I covered earlier, can help facilitate research activities in a virtual setting, ease participant and research staff burden, and eventually lead to a successful development of the online platform that we hope to create. So following these lessons learned can also be transferable to other studies that use virtual settings to conduct research activities, especially working with populations that are older or may not be as technologically familiar with Zoom or other online platforms. Thank you. So I will stop sharing. I know that we're holding questions till the end.
Thank you for that, Karah. Excellent presentation, and you actually did it in less than 10 minutes. So we're always very appreciative of people keeping time. Chenglin, you're up next.
Great. Well, let me share my screen. Can I see my screen? Okay. All right. Good morning, everyone. My name is Chenglin Hong, and I'm a second-year PhD student here at the Department of Social Welfare, and I got my master's degree in social work as well, and public health. And today I'm going to present our work entitled "The Association Between HIV Stigma and Health-Related Quality of Life and Patient-Reported Outcomes Among Black Sexual Minority Men Living with HIV." So in terms of the background, as we all know, the advancement of antiretroviral therapy has transformed the HIV epidemic and changing HIV from kind of a deadly disease to a more chronic and manageable health condition. And in many countries and settings, life expectancy for people living with HIV has increased substantially, which is can be near that of the general population. And with that, a fourth 90% target has emerged. As we all know, the 90% target has been the guide for researchers and practitioners for HIV prevention and care in the past decades. And now more and more people are carrying that the quality of life is held to be the equal importance of the other 90% target. And there's also an increase of using patient-reported outcome data to provide very important information, because people believe that this kind of information can provide critical details about a patient's firsthand account of their experience that cannot be directly measured, and can provide more holistic views of their own health and well-being without any further interpretation and intervention from their providers. And in the past, researchers and practitioners have examined, and identified factors that are associated with health-related quality of life, including, demographic information, behavioral health factors, and among these, one factor that plays a persistent role is HIV stigma, which refers to the discrimination directed to people perceived to have HIV and AIDS, and also the individual groups and communities that are associated with HIV. And research in the past have suggested that HIV-related stigma and discrimination have impacted HIV-related outcome and treatment outcome, including lower engagement of ART and also lower ART adherence and other clinical indicators. And also HIV-related stigma is strongly associated with some other quality of life indicators, such as mental health outcome and quality of life and life satisfaction. As we know, Black sexual minority men are disproportionately affected by the HIV epidemic in the US, and this population normally has been reported having adverse outcomes across the HIV care continuum in the US. A hypothesis is that the effect of HIV stigma may be even pronounced among this population due to the intersectional identities and multiple minority stressors. And in the past, there's studies looking at stigma reduction intervention among people with HIV to improve HIV-related quality of life, but actually very few of them specifically assessed the impact of stigma on some of the quality of life indicators. So the objective of this current study is to document the level of HIV stigma using a validated instrument, the Barger HIV stigma scale, and also assess some of the health related outcomes among Black sexual minority men living with HIV, including mental health outcomes and life satisfaction and quality of life. And we also want to assess whether the associations exist among this population. And data for this study are from a study that tests the Links. Is a web-based mobile app that provides tailored social services, legal resources, and peer support for Black sexual minority men living with HIV in Los Angeles County using a randomized comparison trial. And this is the analysis, the data for this analysis were from the baseline. And we used validated measures such as the Berger HIV stigma scale, the PHQ-9, and some of other validated scales to measure the main study outcomes. And I conducted multivariable linear regression, controlling social demographic characteristics, clinical outcomes, which I will introduce a little bit more later. Here is the characteristics of our 122 study participants at enrollment. So as you can see, the mean age was about 37 years old, and about 1/3 of them were currently employed by enrollment. And about 30% of them actually had an annual income of less than 12,000, which I believe was about the federal poverty line in 2019. And almost all of them, well, I won't say all, but like 95% of them were receiving ART by enrollment, and only about 61 or 62% of them were very surprised. And then about 70% of them indicated having good adherence for ART. And in terms of the main study outcomes, about 1/3 of them were screened for depression and anxiety based on PHQ-9 and GAD-7. And about 30% were either strongly agree or agree that they're pretty satisfied with life. And based on the latter scale, that about half of them are pretty thriving, and another half of them actually were struggling and suffering due to a variety of reasons. And here, I'm sorry about that, there are a lot of information, but I really want to highlight that. So the Barker HIV stigma scale actually assessed 4 sub-perspectives or dimensions of scale, including personalized stigma, such as they have experienced stigma discrimination because of having HIV, and also disclosure concerns, negative self-image, and public attitude. And I really want to highlight that among our study participants, there were large proportions of them reporting have disclosure concerns, such as they're very careful about who they tell they have HIV, and also the perspectives on public attitude. Most of people think that having HIV is disgusting, or most people with HIV are rejected when others find out. And the next slide this is the correlation between the HIV stigma and some of other study outcomes. So as we hypothesize that HIV stigma is higher levels of HIV stigma is associated with higher levels of likelihood of having mental health issues. And from the multivariable linear regression, after adjusting for all the variables that included in the model, we found that HIV stigma is associated with higher levels of mental health outcomes and lower levels of life satisfaction and quality of life. And also having a history of being attacked and harassed in the past year also associated with, negatively associated with life satisfaction and quality of life. And the last one is receiving ART was also, have the anticipated result as the hypothesis, having positively associated with life satisfaction. So the result of the analysis suggested that there was a higher level of HIV stigma among Black sexual minority men living with HIV in Los Angeles County. And there's a big proportion of them, as I said, have concerns on disclosure issue and public attitude. And I like experienced or enacted stigma. Both disclosure concerns and public attitudes are perceived or anticipated stigma, which refer to the degree that individuals expect that they will experience some judgment, discrimination from the community and from other people. So I think this is of great importance of future stigma reduction interventions that should focus on these perspectives. And also, we found a high risk of mental health burdens among our participants, which indicate the need to promote mental health screening and services in HIV clinic and other service settings. And also our findings found the critical association between HIV stigma and patient-reported outcomes. And especially we found that has the history of being harassed and kind of the violence victimization is associated with adverse quality of lives. So trauma-informed care may be critical to improve quality of life and satisfaction. And we think that reducing stigma and improving good health-related quality of life is important to achieve the fourth 90% target among Black sexual minority men living with HIV. And no study is without limitations. So the first limitation of our study is actually the Berger HIV stigma scale didn't assess different types of stigma, such as enacted stigma, perceived stigma, or even internalized stigma. So this would be important for future design as well. And the data were self-reported, so it may subject to record bias. And also, as I said, most of the study participants were receiving ART. So whether the association persists is unknown among those who are not receiving HIV care. And also this is more like a cross-sectional design for this survey, but the study is longitudinal, and we're excited to see the study effect. And I want to acknowledge Professor Ian Holloway, who is the PI for this project, and also our CUP members who provide a lot of insightful ideas and perspectives from the community, and our staff at UCLA and the HIP. And lastly, thank you. Look forward to answer your questions. I think I'm on time, right?